Welcome to our podcast, Psychiatric Services from Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today, we're going to talk about a really cool article, focused on lived experience and how it might influence burnout. I'm looking forward to this.
We're very fortunate today to have Dr. Courtney von Hippel, who is an associate professor of health and behavioral sciences at the School of Psychology at the University of Queensland, here all the way from Australia to talk with us about her paper, Lived Experience as a Protective Factor for Mental Health Workers. So, Dr. von Hippel, thank you so much for joining us on this late evening for you, early morning for us.
Yeah, thank you for having me, and thanks for getting up so early. So I don't have to stay up too late.
Yeah. So we'll start out with just a general question about how you got involved in this research.
Well, this particular paper is following up some work that we did a couple of years ago. My background is in psychology of the workplace, so organizational psychology. So I'm really interested in factors that can help improve people's lives in the workplace. And so a few weeks ago, I was talking to a group of students. The Psychology Students Association put on a research night where they brought in people in the School of Psychology at my university to talk about the research that we do. And you may not be surprised to learn that most people study psychology because they want to help people with their problems. But most of our students want to go into clinical psychology. And there's just very few spaces in graduate clinical degrees. And so, I kind of want to work on them when they're a bit younger and more pliable, I suppose, to get them thinking about, well, if your goal is to help people, then maybe you should be studying organizational psychology, because we spend most of our time in the workplace. If you look at what we spend our day doing, we sleep first and foremost, and then the rest of the bulk of our day is spent in the workplace. I'm interested in how we can make people's work lives better. And to the degree that people are happier at work, they're more satisfied, they're more engaged, that's probably going to spill over into other parts of their lives. Just like if you're having all these difficult times in the workplace, you have a lot of social friction with your boss or your colleagues that can spill over outside of the work. So a lot of the work that I do is looking at ways in which we can help people to have more fulfilling workplace experiences. And along with this, though, I'm interested more generally in psychology, and I've done some work with some clinical populations. So people with schizophrenia, people who might suffer from addiction, injecting drug users, et cetera. But the clinicians or the mental health workers or the support workers that help these people who are struggling in their lives, that's a really difficult profession to be in. It's a profession where there's a huge amount of burnout. So people oftentimes wind up leaving the field prematurely. And it's a profession that can be really rewarding, but also really difficult and challenging because mental health problems are hard to treat. There's lots of things that can contribute to burnout. So being in an underfunded, under-resourced environment, having a lot of emotional labor. So, constantly needing to smile or not show that you're upset, that can lead to burnout. Having lack of good support from your supervisor can lead to burnout. But one of the things that hasn't been looked at is if I feel like I'm putting all this time and energy to help people with their mental health problems, but I don't feel like I'm being successful at it, I don't feel that my help is actually improving the lives of the people I'm trying to help, might that also lead to burnout? And interestingly, that hadn't been looked at before. So in a study that we published a couple of years ago, that was essentially what we were looking at. Is it to the degree that I feel that my help is in improving the lives of the people I'm trying to help, will those mental health providers experience what's called client-related burnout? So the burnout that you feel from the emotional exhaustion, because I'm not sure if you know what burnout is, but that emotional exhaustion and in fact, physical exhaustion as well, just from working with clients day to day. And to the degree that I feel that my help isn't improving the lives of my clients, am I more susceptible to that kind of burnout? And it turns out that, yes, that's also a contributor of burnout.
In this paper, you're building upon that past work. And it seems important both in terms of the research you're doing, but also in terms of the methods you use to really lay out like a very clear pathway of your hypothesis, how like one thing leads to another. And so let me take a stab at summarizing what you've said is that you might have a client who is you're working with in a challenging setting who's not getting better. Because of that, the provider might experience some sort of burnout, and that might lead to what? What's the kind of final end outcome of that?
Yeah. And so there is lots of research literature on burnout. And so we know from that literature that to the degree that employees experience burnout, they're less satisfied with their jobs, they're less committed to their jobs, they are less engaged with their jobs. So, and I'm talking about these as separate kind of workplace outcomes, but they do overlap quite a lot. So it's probably not a surprise that if I'm not satisfied with my job, I'm probably not that committed to it either, and I'm not all that engaged. Burnout leads to these different workplace outcomes. And most importantly, probably in these mental health settings where turnover is a real issue, that to the degree that people experience burnout, they're more interested in quitting their jobs and ultimately more likely to leave their jobs. So, an area, for example, where there's huge burnout and huge turnover problems is child protection. It's an really difficult job to be in, even though you're making a huge difference in people's lives. Ultimately, it's exhausting having to manage all of those crises all the time, and it's very depressing and upsetting. And so it's also not a very well-paid job either. So there's fields like that where turnover is a huge issue, and mental health, well, community mental health in particular, obviously there's some mental health providers who are very well paid. But in terms of community mental health, where we've been doing our research in this area, they tend not to be well paid. It's not a very high resource environment. There's huge caseload demand. So you have lots of people that you're trying to see and help. Your hours are demanding. You're not getting paid that much money. And although it can be really rewarding, it also can be super challenging. And so because of all of these different kinds of things, there's also tends to be high turnover. So people are leaving the profession. And that's really problematic as well for a variety of reasons.
Courtney,
First,
can I just interrupt for a sec?
Yeah.
What I understand you're saying seems relevant for people who have a job, right? Who are employed by a community mental health center or by a human service agency. Many people, at least as I've seen now, have a private practice or a individual practice.
So the work that we've done in this area is with community mental health organizations. So these aren't people who are in private practice. And oftentimes they don't necessarily have PhDs in psychology. They might be social workers. There's a lot of peer support workers. But I think there's both challenges and benefits of being in private practice. If you're in private practice, you're going to have more control over your case load. And so you're in a position to turn people away if you feel that you're working too much. But if you're in private practice really on your own, then you don't necessarily have that support of the workplace behind you, where you can talk to a colleague and get some advice on a tricky case that you're trying to deal with, or get someone else to provide another opinion. Now, of course, it's good practice to have that support network, even when you're in private practice. And I can't speak to how it works in the US because I've lived in Australia for so long. But certainly here, the expectation for young psychologists is that they would be getting supervision and they would be getting that help regularly. So that way you're not doing this on your own. But it may be a very different story, but it would still be, I think, a profession where there is a lot of burnout because of all the reasons that I was saying earlier, in that it's very challenging, it's demanding. Recovery is oftentimes not linear. And oftentimes we go into the field with this notion that, I guess, a narrower definition of recovery. And then once you're working in it, you realize that you need to have a really broad definition of recovery. Recovery doesn't mean I'll no longer have this problem. It means that I can manage it better. And so it may be that I'm feeling better more days of the week, but it doesn't mean that, I'm struggling with schizophrenia or with bipolar disorder, that these things are just, they don't disappear. It's just an issue of leading a more fulfilling and rewarding life. And so recovery isn't necessarily, I'm all better now.
I think adding that complexity is so important because it's also some aspect of someone's life might get better, while another aspect of someone's life might still be complicated. One solution might present a new problem. Getting back to the paper, what your hypothesis here is that a provider's lived experience of having their own mental health issue might inform their work, but more importantly, might change the way that there's that interaction between working with challenging clients who have complicated recovery stories and burnout and ultimate workplace satisfaction or satisfaction in the field. So can you kind of walk through how somebody's lived experience, a provider's lived experience might change things up for them as they're working in these challenging environments?
There's a variety of reasons that we thought lived experience might be beneficial. I should say that we don't have data that speak to that. So what I'm going to go through now is just our musings on the issue. And one of the things, because I've been most of my career doing work on employees and organizations, is in order to maximize the likelihood that people are going to complete our survey, we need to keep it short and sweet. And so, although we want to look at all the different mechanisms of why lived experience might be beneficial, that is reserved for follow-up work. But so why might it be beneficial? Well, for starters, I have knowledge of my own recovery challenges. And so I know that when my clients aren't improving, that this is part and parcel of the recovery process. And so the fact that they're not improving may not be as likely to lead to burnout for me if I have lived experience. Part of it might be that recovery knowledge. It might be knowledge of having to navigate the mental health provider system myself, and knowing the challenges inherent of that make me more sympathetic and more empathic about all of those challenges around that. It may be that when I see my clients have setbacks, when I see they're not recovering, that I'm making more positive attributions for that. I'm making an attribution that it's something to do with the situation, not something to do with that person's lack of organization or lack of motivation, etc. So I think there's a variety of reasons why lived experience might buffer mental health providers from experiencing burnout when they feel their clients aren't improving. But in this first test, what we were trying to do is see if that was in fact the case. We haven't tested why that might be the case. The question was, gee, we know that to the degree that you feel your clients aren't improving, you're susceptible to burnout. And burnout has these negative downstream consequences where employees are less satisfied, they're less engaged with their jobs, they have poor workplace well-being. And importantly, like I was saying earlier, they're more interested in quitting the profession. And that's a problem because you've put in lots of resources to train people. Now, all the people that the mental health provider was seeing doesn't have that continuity of care. And so you've built this relationship with someone and now they've left. And so turnout ultimately is really problematic. And so might it be the case that lived experience might help to cut through this and might stop this whole, the downstream consequences of burnout, if that makes sense.
Well, it makes sense, but it resonates with my own personal experience where it's like some things get better pretty quickly, right? Some things are pretty easy to change. And then some things take a really frustratingly long time to change around in like the way that you operate in the world. And that's been something that I've thought about a lot in working with clients. Well, it's like some things just are like, this is a journey that we're on, and it's not a week to week thing. It's like a year to year thing. Whereas other things might change from one appointment to the next. And so I think just the idea that your own experience really informs the way that you see change or lack of change in a client, that idea really resonates with me. So I was fascinated by seeing how you operationalize this to look at that. So let's talk about that for a second. Before we dive into some of your results, could you talk a little bit about the setting you were looking at, who the respondents were, and maybe just to make things concrete for people, just an example of the sort of questions you were asking around these issues about client improvement burnout, workplace outcomes, and lived experience?
Like I was saying earlier, the work that we've done in this area has been with community mental health providers. So essentially, their goal, their remit is to help support members of the community so they can meet their everyday challenges, lead more fulfilling lives. But these are like community members who have significant mental health struggles. This particular organization the data that we're talking about now, they actually have a lot of peer support workers who work for them. Now, I don't know how much of people want to make a distinction between peer support workers and lived experience, but the distinction that we're making is peer support workers are being employed specifically as a peer support person. This is someone who has lived experience, but there are people who are working in mental health, not in a peer support role, and they may or may not choose to share that they have lived experience, that they too have been there, and what their background is. And these are the people that we were really focusing on, is people who are not necessarily working in a peer support capacity, but rather have lived experience of mental health challenges. So this organization emailed our link to their employees, encouraging them to complete the survey. Despite that, we only had 23%, roughly, I can't remember exactly, of employees who actually chose to complete our survey, despite the fact that you could go into a prize draw to win a gift voucher. And despite the fact that the survey is advertised as taking less than 10 minutes, a lot of employees feel over-surveyed, especially in these kinds of settings. But they basically just get an email, they click on a link, it takes them to our Qualtrics survey that's hosted at the University of Queensland, and they take the survey. In terms of the questions, we're mostly using scales that are really well established in the literature, that have been shown to be reliable and valid. So for example, job satisfaction, they answer, 5 questions that are around things like, oh, most days I'm enthusiastic about my work. Whereas intentions to quit are, I'm seriously considering quitting this job for an alternative employer. And so we essentially have several questions that are tapping each one of these outcome variables that we're interested in. For burnout, we were looking, like I was saying earlier, specifically at client-related burnout. So the degree to which people are feeling this exhaustion and fatigue from working with clients. So does it drain your energy to work with people who access your services? These are the kinds of like self-report questions, but then we also wanted to know the degree to which they felt their clients are improving. And in our earlier paper that we published a couple of years ago, we asked people about the percentage of their clients who they felt were improving versus not improving. And in the interest of sort of replicability and to ensure that there wasn't something specific about the way that we had asked that question, we purposefully wanted to ask it in a different way. We asked them more generally if they felt that the support that they're providing is enabling their clients to live better lives. And we had 2 questions about that in terms of the people who are accessing their services and whether they felt that the support they're providing is helping their clients, essentially. So we looked at it in a different way. And then lived experience, we just asked them if they identified as someone who had lived experience, yes or no. Yes. So does that give you a good sense of what the survey looked like?
Totally. To summarize, before we get into the results, community mental health setting, you're looking at providers, and then you're asking them about their perceptions of the client improvement, whether or not they're feeling burnt out, how their job satisfaction, intentions to quit the field or the workplace are, and then you're asking about lived experience, and you're seeing how all those relate to each
other. Exactly. Yep. Perfect.
So what's the answer? What did we find out?
So I think, again, back to sort of replicability, importantly, we perfectly replicated our earlier findings, whereby to the degree that you felt your clients were not improving, you're more likely to experience this client-related burnout, which in turn led to people to be less satisfied with their jobs. They had lower job engagement. They had increased intentions to both quit their current position, but also quit the field in general. And so there were these, again, downstream consequences of burnout. But importantly, and what we've done that's gone beyond our earlier work is we've looked at that role of lived experience. And again, the idea was, can lived experience buffer employees? Does it serve this protective role of, to the degree that my clients aren't improving, I understand that that's part of it. And so I'm less susceptible to experiencing burnout when I feel my clients aren't improving. And in fact, that's what we demonstrate. So lived experience is protective. So, and I should note that we had a lot more people who had lived experience than didn't have lived experience, but nonetheless, to the degree people who had lived experience, that relationship between perceptions that clients aren't improving and burnout was much, much weaker compared to people who didn't have lived experience.
So it sounds like your hypothesis was confirmed.
Yes.
in your findings. Was there anything about your findings that were surprising to you?
I think part of, and what I didn't mention earlier in terms of how I got involved in this research, a lot of my research is looking at groups in the workplace that are stigmatized. And there's not a ton of work on lived experience amongst people working in the mental health profession. But to the degree that this research exists, and maybe more so for people who work in the alcohol and other drug sector, there's concerns that people who have lived experience in these areas, they feel stigmatized in the workplace. And if you feel stigmatized in the workplace, we know that you're going to have more negative job attitudes. So I kind of expected, although not to the point where I would have predicted it, but I just assumed that to the degree that people had lived experience, they might have more negative job attitudes because they feel stigmatized in the workplace. We actually found the opposite. The people who had lived experience tended to have more positive attitudes. They tended to be more satisfied, less likely to quit their jobs, and had higher workplace well-being. So that was pretty unexpected.
So can you speculate, and I know you didn't study this, but I'm curious about the relationship between lived experience and self-disclosure. They're not the same thing, right? But in my own experience, lived experience is kind of more accepted, but self-disclosure is more cautiously sort of viewed.
Yeah, and that's actually one of the things that I'd like to follow up is to get a sense of lived experience and how that impacts on client outcomes. And in part, is are providers disclosing their lived experience to their clients? And if so, how is it impacting their clients? Because exactly what you said, oftentimes, I mean, on the one hand, having knowledge that the person who's helping me has walked a similar path, they've struggled with their own recovery journey, can be really beneficial. But like you've said, it's potentially crossing a line where it's inappropriate to disclose that information to your clients. So I think it would be really interesting to explore these ideas further and to get a sense of, are people disclosing? When are they disclosing? And how is it benefiting or detracting from the relationship with the client and how it is impacting on client outcomes?
It seems like there's so many follow-up questions around the lived experience part of the paper. I mean, one thing that came to mind for me was the type of lived experience. Like, as somebody who has an experience of mild to moderate anxiety and depression, but is working with people who are in the settings that you looked at who have schizophrenia, psychotic spectrum disorders, like, does one translate to the other in some way, or does it have to be more congruent? I don't know. I found it very thought-provoking, just in that lived experience piece. And as Lisa was saying, the self-disclosure, it seems like there's a lot more digging to do in that aspect of the pathway that you're describing.
Yeah, that's actually an excellent point. And it's not one that I had thought about. We really, like I said earlier, we just asked people if they had lived experience or not. We did then have a follow-up question about how much they felt it had impacted their life to get a sense of, but we really didn't use that in the analyses at all. But you're absolutely right. Is it the case that my lived experience is going to be most beneficial when we have the same mental health concerns that we're struggling with? Or is it just lived experience in general? And I think as well is, if it's more severe lived experience, is it potentially going to make it more difficult in the workplace because you feel more stigmatized? Or is it going to be even better for the people that you're helping, because you are more of a role model to show that, yes, at one point I was suffering from homelessness, and this, whatever it is, I was locked up in an institution against my will. And now look at me. I'm, seeing and helping people in their lives. And that could be super inspirational. So I think there's a lot more that could be done around lived experience, like you've just said. So thank you for that idea.
Is there anything that's actually in the pipeline in terms of next steps for research? Because I think the general, where you started was talking about organizational psychology and workplace outcomes. And I think this is like a very, very crucial topic right now with a lot of the workforce struggles that I think are happening in the field, at least in the States. And I wouldn't be surprised if they were also happening in Australia as well. So either in this arena or in your more general research interests, what's in the pipeline?
In terms of in this area, we have a survey that unfortunately there hasn't been much uptake. The organization has promoted it, but we haven't had enough people completing it. But essentially extending this work into the alcohol and other drug sector. So working with a peak body who has promoted the survey. And in that, what we're trying to do is uncover those mechanisms. So why is it the case that lived experience is providing this buffer? So we're both trying to extend it into new area, but also try to get a better handle on why lived experience is beneficial, because by understanding that, we're in a position to try to help employees in general benefit from the knowledge of lived experience. So if it's the case that lived experience helps minimize the experience of burnout when you feel your clients aren't improving, because people make these more positive attributions. They're more likely to make a situational attribution when there's a setback rather than a dispositional attribution. Then we can help to train people in general when they're, starting in a job to make these kinds of attributions. Or if it has to do with just simple recovery knowledge, they have a better understanding that recovery isn't linear. Then we can train, we can educate the workforce about the recovery journey and what to expect. One of the things that we originally thought before we understood that lived experience provides a buffer, we thought what we need to do is help supervisors to help the people who are working for them to celebrate small wins, because then if you feel that your clients are improving more than you originally thought they were, then you should be less susceptible to burnout. So there's lots of directions in which it can go, but the idea ultimately is to understand why lived experience can buffer people from client-related burnout, these mental health providers from that, so that we can kind of try to bottle that and allow other people to benefit from that.
Well, we'll stop there and want to thank you again so much for joining us. It was a real pleasure, really thought-provoking conversation. So thanks again.
Thank you so much for having me. And again, thanks for getting up so early so I don't have to stay up too late. It is past my bedtime now, but it's a public holiday here tomorrow, so I can sleep in.
Oh, okay. Well, we don't feel so bad anymore. Well, thanks again. And
thank you.
We look forward to seeing more of your work in the future.
Thanks. Lovely to meet you both.
Well, that's it for today. We invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research. We also welcome your feedback. Please email us at psjournal@psych.org. You can also rate and review the podcast on iTunes, Stitcher, or wherever you listen to it. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you for listening. We'll talk to you next time.
The APA has other podcasts you can listen to. This month on AGP Audio, Dr. Kenneth Kindler discusses the origin of psychiatry, and Dr. Ned Kalin puts the May issue of AJP into context. You can check out that and other podcasts at psychiatryonline.org/podcasts.
The views and opinions expressed in this podcast are those of the individual speakers only, and do not necessarily represent those of the American Psychiatric Association. The content of this podcast is provided for general information purposes only and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.